Well, good afternoon. Thank you all for joining us today. I am Allison Drew. I am the program coordinator for the Iowa Regional Autism Assistance Program. Welcome to Autism Basics Webinar Series featuring Dr. Kelly Pelzel. This session is titled, What is Autism? And we are so glad to have you all here today. I do want to give a friendly reminder that the certificates of attendance and foster parent training credit are available for the live sessions only. And now I am happy to introduce Dr. Pelzel. Dr. Kelly Pelzel is a licensed psychologist and a clinical assistant professor working in the University of Iowa Stead Family Children's Hospital, Child and Adolescent Psychiatry Division. She received her BA from the University of Northern Iowa, and Dr. Pelzel received her PhD from the University of Utah. She completed her pre-doctoral psychology internship at Primary Children's Hospital in Salt Lake City. Dr. Pelzel completed a leadership education in neurodevelopmental and related disabilities postdoctoral fellowship at the University of Iowa Stead Family Children's Hospital Center for Disabilities and Development. She provides assessment and treatment services, and Dr. Pelzel also serves as the clinical coordinator for the University of Iowa Stead Family Children's Hospital Autism Center and the psychology consultant for Iowa's Regional Autism Assistance Program. And as we go through the session, questions can be typed into the Q&A box, and Dr. Pelzel will respond to them at the end of the session as time allows. Now I'll turn it over to you.
Thank you, Allison, and thank you for that introduction and for assisting me today. Good afternoon, everyone. I am very happy to be doing this webinar series once again. We've been doing it for several years now, and we're always trying to kind of update it and keep it fresh while I'm still getting you the basic information about autism and what we know in terms of treatment and educational programming and all those things we're going to be talking about in weeks to come. I think I'm going to go ahead and turn off my video while I'm presenting and then turn it back on again for questions and answers. So I'll do that now. Okay, and I want to start by today, before we get into talking about autism and kind of an overview of what it is and how we diagnose and what we think causes autism, those kinds of things. First, I want to start with just a little bit about the Regional Autism Assistance Program, in case you're unfamiliar with RAP. So the Regional Autism Assistance Program is part of Child Health Specialty Clinics here in Iowa, and Child Health Specialty Clinics are overseen by the UI Division of Child and Community Health here in the Department of Pediatrics. And these are clinics across the state that provide care for children and young adults with special health care needs. And RAP teams help Iowa families navigate local supports and services for autistic children, teenagers, and young adults, so up to age 21. I want to stress it's for Iowa families. So sometimes we have families call from Illinois or other surrounding states, and they're really funded to just support Iowa families. And so just a second here. Thank you. Okay, so they are just set up to support Iowa families at this time. But they can help with connecting to autism information, communicating with diagnostic facilities and healthcare providers, working with families to explore what their insurance coverage looks like and other payment options for therapies such as applied behavior analysis or other intervention needs, and can help families navigate the education system. And the RAP team is comprised of a few people at the clinic, but the main touch point is the family navigator. who is the parent of a child with special health care needs. And that is the person who you would be communicating with by phone or email or both, who would be able to hear your concerns, offer support both emotionally as well as being able to connect you tangibly with supports and services based on your family's needs and your goals. And there's no cost for this service, for the family navigation service. It's paid for by state tax dollars. And there at the bottom is some information on how you can connect with a family navigator if you're not already connected with one, through Erica Hertel here at the Child Health Specialty Clinics. And you can also just Google Iowa Regional Assistance Program or Iowa Regional Autism Assistance Program, and it'll pop up in terms of how to get connected, as well as they have a really nice website with lots of information on there, including a wonderful getting started packet for newly diagnosed families. We will have some questions at the end, as Allison noted. Also put my email address up in the at the end. So if you wanted to individually email me, or you think of a question later on, I'm happy to correspond with you that way. As a psychologist, my background's a little bit different than the family navigators. I've been a child psychologist for a while now. First at a hospital in Cedar Rapids, then at Center for Disabilities and Development here at the university, and now in Department of Psychiatry. So I've done autism evaluations and had therapy appointments for many children and families through the years, but through kind of different clinics and hospitals over time. As you may know, there's a lot of talk and thoughts about person first and identity first language right now in the autism community. So whether you refer to someone as having autism or being an autistic person, and I will try to interchange those two preferences, given that there's probably a variety of preferences on the call or on the webinar today. The other thing I just wanted to mention is that some of the material I'll be covering has kind of an Iowa focus. And this is particularly true actually down the line. Maybe that fourth webinar is on educational programming, and that one probably is the one that's heaviest in terms of material with an Iowa focus. Okay, so I think we're on to the actual material now. And this is what I'm hoping to cover today. So first, I want to talk about autism just kind of generally, and then outline how autism is diagnosed. So the process of evaluation. And then we will talk about some causes of autism and summarize. Oh, well, I'll just say a little bit at the end about research on early signs and symptoms and early trajectories for autism spectrum disorder. Some stuff that has been more recent research that I think is important, both in terms of intervention as well as early identification of autism. So, if we were all together and doing this in person, we'd probably do this more as a discussion. But I want you to start thinking in your head about, when you think of autism, what kinds of images or characteristics come to mind for you? And what does autism look like in terms of how you think about autism? And I bet if we were together and starting to list things, we would start to have quite a long list and quite a variable list of things that we're all thinking about when we think about autism, because it is pretty variable in terms of presentation, which we're going to talk about here in just a sec. So one way we can kind of do this, since we're on that all together, is to think about some pop culture stuff, both real individuals who are a part of, have a media presence. So on the left-hand side here, I have real people. And then on the right-hand side, I have characters. So we have people from sitcoms like Community and Big Bang Theory on the right side. We have Temple Grandin. We have Love on the Spectrum cast there. I think the original cast up there in the top left corner. And in terms of kind of pop culture, these have been pretty prominent representations of what autism or autism-like symptoms and behaviors look like. But I also just want to mention, and we'll talk about this a little bit later too, I think, but there is a little bit less representation in popular culture of individuals with what they call profound or severe autism. We're going to talk about what the DSM is here in a second. But basically, these are individuals who meet criteria for autism spectrum disorder, but also have either cognitive and or functional impairments that require that they have continuous or near continuous supports and supervision. So individuals in this category are often nonverbal, have limited use of language, have intellectual impairment, and a subset exhibit some challenging behaviors like aggression, self-injury, property destruction that interfere with their safety and their well-being. And so yeah, this part of the spectrum is less well represented. Although there was a show last year on Lifetime, a reality television show called Leave It to G. I don't think it got renewed. About a woman with a family, and I think she was a breast cancer survivor. And anyway, has a son with profound or severe autism. But this is definitely like the exception to the rule. Usually this part of the spectrum gets left out of popular media and popular culture. But it does make up a substantial minority of autistic individuals, and they're kind of trying to get a handle on definitions. So you see kind of a wide line here in terms of 18 to 48%, depending on the study. That's because they haven't really settled on a definition for this yet. And the idea with this is we're thinking a lot about making sure everyone's needs get met, and possibly maybe that means going back to a system where we have perhaps multiple autism diagnoses, which we've had in the past. Currently, we just have one. So something to think about there when we're thinking about those characteristics of someone with autism. But across the spectrum, in order to meet criteria for the diagnosis, regardless of other components going in, there's some core things that everyone has to meet. And this is kind of boiled down to what we think the core components of autism are. So first, it's a developmental disorder characterized by varying degrees to difficulties in the areas of social interaction, verbal and nonverbal communication, and restricted and repetitive behaviors and interests. And visually, this would look something like this, at least how we kind of currently have it conceptualized. So prior to the way we currently diagnose, we actually had social symptoms and communication symptoms kind of split out into two separate groups. But it turns out those are things that are very hard to separate because they're so dependent on each other, communication and social skills. And so they think the better way to kind of conceptualize that right now is to combine those into more social communication symptoms, like all together. And then that second group of symptoms of restricted and repetitive behaviors and interests. I'll show you what that looks like in terms of the symptoms here in a bit. But first, just a few quick facts. So currently, the prevalence rate for autism spectrum disorder is 1 in 36 children. This is measured frequently by a national group that looks at the rate of autism. They look at, I think, about 8 or 9 different states. And they look at 8-year-olds, what the prevalence rate is in 8-year-olds. And when they first started doing this, like around the year 2000, the prevalence rate was 1 in 150. So as you can see, just in the last like 20 years or so, the prevalence rate has definitely risen for this diagnosis. And there's many reasons for that. Certainly the way that we have it conceptualized now in terms of the spectrum and what we call autism versus something else has really changed over the last 20 years. The percentage varies a little bit by location. So in states where you have a lot of diagnosticians and you have a lot of really good services, you do see a lot of autism compared to states with fewer diagnosticians, fewer services. What does hold kind of across the board is there's usually about 4 autistic boys for every 1 autistic girl diagnosed. There used to be a difference between the number of African American kids that were diagnosed compared to Caucasian children. That's no longer the case. That's no difference between ethnicities there. However, the number of Hispanic children identified with autism is still comparatively lower to the other 2 groups. When we think about autism, that core symptomology that I talked about needs to be present in some way in very early childhood, but how much of it is there and what severity is present at that time can be pretty variable. We think it's a stable disorder, so there's no cure for autism spectrum disorder. There are many evidence-based interventions that target specific skills. It is heritable, but it's not a situation where we can say, for the most part, like this is the gene or this is the single contribution that caused the autism. We're not there, but we do think it has a high we know it has a high heritability rate. Co-occurring conditions are common, so about 1/3 of individuals that have autism also have intellectual disability. Anxiety and ADHD are also very common. The annual cost of supporting autistics in the US is between about 236 and 262 billion, depending on the prevalence of intellectual disability. And on an individual basis, the lifetime costs again kind of vary depending on the presence or absence of intellectual disability and how much support the individual needs. It's been about, about 53 years since autism was first listed as an official diagnosis, but people have been talking about this presentation for much longer than that. And even thinking way back to before there were psychiatric diagnoses and manuals and such to diagnose them. You may remember from your like Psychology 101 class or something like that, when they talk about nature versus nurture and things. There's a famous case from France from a long time ago of a boy named Victor, who was found abandoned in a forest and was kind of studied, and he exhibited many symptoms of autism spectrum disorder. If you kind of read about the case study now, it sounds a lot like autism. Of course, he was abandoned in the woods, so he had a lot of environmental things going on, and there's a lot of questions there about trauma and neglect and all of that. There's another really interesting case from way back when too. A guy named Hugh Blair who basically was set in a family, a wealthy family, and set to inherit some land. And there was dispute between the siblings, I believe, about whether he was competent to inherit this land. And it went to court. And because it went to court, there's like a lot of like detailed information about what he was like. And if you read through that case study, it's also looks pretty clear cut like autism spectrum disorder is what they're describing in this individual as well. And there's a really cool book about him that was written by a historian and a autism researcher. They wrote it together, and I'd encourage you to take a look at that if you're interested in historical stuff like that. Fast forward to early 1900s, that's really when the word autism is first used to describe something. In this case, it's used to describe a subset of schizophrenic patients. And then in the war years, 1943, first American child psychiatrist Leo Kanner published a paper describing 11 kids. It was a case series who were very intelligent but displayed a powerful desire for aloneness, obsessive insistence on persistent sameness, and a bunch of other things that are very in line with our diagnosis of autism spectrum disorder today. And in that same period of time, again, the war years, there's a German scientist named Hans Asperger, who also was describing kids that had high intelligence but trouble with social interactions and specific obsessive interests. And there's been lots of back and forth over the years about Hans Asperger's and whether he was a Nazi sympathizer or not. Current evidence suggests that he was, but yeah, that's been a really interesting development in terms of kind of the history there. So yes, so people were starting to talk about autism or Asperger's disorder, which was an autism diagnosis for a while, way back in the 1940s, but it wasn't until, like I said, 1980 that infantile autism is first recognized in the manual that we use to diagnose psychiatric conditions and kind of officially separated from the diagnosis of childhood schizophrenia. So now we're all the way, that was DSM-3. Now that we're all the way up to DSM-5.5. The TR means like after a revision's been out for addition's been out for a while, they usually do a little revision and clarify a few things, maybe add a few things. So in between editions, you usually get this text revision version of the DSM, and that's where we're at, is kind of version 5.5 here. And they didn't do too much between DSM-5 and DSM-5 TR to change autism spectrum disorder, but there's a couple exceptions which I have circled here. One is as they lay out the social communication symptoms that all individuals with autism diagnosed with autism spectrum disorder need to meet, they really made it clear that you have to have all three of these. I thought it was pretty clear before, but apparently there was some question there about whether people had to have all three. And so they've said, yes, you have to have all three of these social communication deficits in order to have a diagnosis of autism spectrum disorder. So the first is some deficits in social emotional reciprocity. And you'll see here with all of these, there's really a range of what that means, from maybe some, awkwardness in terms of social approach and how you respond socially, or some difficulty having that back and forth conversation, to really, an absence or a failure to initiate or respond to social interaction on the other end of that spectrum there. Deficits in nonverbal communication is the second criteria. So this is ranging from having some difficulty integrating eye contact with some other verbal and nonverbal behaviors like gestures and words, to really like an absence of gestures and facial expression and eye contact. Third symptom is deficits in developing, maintaining, understanding relationships. And again, this can be just difficulties kind of adjusting behavior to fit the social situation, to things like having difficulty sharing an imaginative play, making friends, to really not being interested in interacting with peers. Okay, so that's on the social side of things, social communication side. On the behavioral side, so those restricted and repetitive behaviors and interests, there are 4 symptom areas And to be diagnosed with autism spectrum disorder, you have to have symptoms in at least 2 of these areas. So I'll just kind of run down through them. First is repetitive motor movements, use of objects, repetitive speech, or stereotype speech. So these are things like motor stereotypies, like hand flapping, lining up toys or playing with toys in a very repetitive kind of way. Echolalia, so repeating words over and over, using odd phrasing when you're describing things. So that's symptom area 1. Symptom area 2 is insistence on sameness, or having like a really inflexible adherence to routines, even though it's not functional, or ritualized patterns of behavior or nonverbal behavior where things have to be done or said in a very specific way. So these are individuals that have really a lot of distress at small changes to their schedule, some difficulty with transitioning, really thinking rigidly or inflexibly about things, like wanting to take the same route to school each day, eat the very same kind of food every day, that sort of thing. Third area is highly restricted, fixated interests that are abnormal in intensity or focus. So this would be kids who or adults who really get into a certain subject, either something that is something that a lot of people like, but they really take a deep dive into it, or something that most people don't spend a lot of time studying or talking about or getting interested in, but they tend to have a persevetive interest in that. And I'll just say, in a way that interferes with other activities in their life, for this criteria. And then the fourth area is related to sensory symptoms. So either being underreactive or overreactive to sensory input, meaning like the way things look or taste or feel. So some kids have like indifference to pain or temperature changes, or a really adverse reaction to certain sounds or textures, tastes, or some fascination with things like the way things hit with light or the way things move, where they want to take a special look at that. And so those are the sensory symptoms. And again, there's these 4 symptom areas, but to meet criteria, you just have to have 2 out of 4 of the areas. A few other things about the criteria. One is that the symptoms, like I said before, have to be present in the early developmental period. But how many are there and kind of what they look like really does range. And so a lot of these things may not become super apparent until there are more social demands on the individual that start to exceed those capacities. So an example of that is maybe that third social communication symptom of understanding relationships and that sort of thing. There's kind of limited ways that we can talk and think about that when kids are really, really young. But as social demands grow in childhood, then you can start to see some of those difficulties a little bit better. Or the other thing that can happen is that individuals can show some symptoms early on and then learn ways to kind of hide or mask some of those difficulties that they may be having or some of those deficits. So a good example of this would be sometimes people can learn to kind of, I'll say fake, I don't know if that's the right word, but kind of like get away with like not quite making eye contact, but it's not super apparent that their eye contact is poor. So they may be looking close to another person's eyes, but not directly at their eyes. And that may be a strategy that they've learned because they have told them like about the importance of making eye contact and things like that. So that's an example of something maybe being masked later on that you would see as problematic when they were young. And as I kind of mentioned with like the perseverative interests, the symptoms have to cause some impairment, like in their social life or their job or other important areas of functioning. And the disturbances or differences are not better accounted for by something like intellectual disability or global developmental delay. Because when we had autism spectrum disorder split out into multiple diagnoses, basically the diagnoses that they had in the manual didn't really line up with reality in terms of how people presented. So that's why they kind of got rid of that system and went to just autism spectrum disorder. But they still wanted some ways to kind of describe different types of individuals that would meet criteria. And so they came up with some specifiers. So when individuals are diagnosed with autism spectrum disorder, typically these specifiers are also called out in terms of the person's presentation. So whether or not they have an intellectual disability, whether or not they have language impairment, like a language disorder, whether or not there's a medical or genetic condition or some sort of environmental factor that would be a potential cause of the autism spectrum disorder, and whether or not the person has other neurodevelopmental, mental, or behavioral health problems. I circled problem because this is the other thing that they changed with DSM-5-TR. Is this used to say disorder, and that's no longer the case. It doesn't have to be that they already have been diagnosed with the disorder. If you're seeing an individual for an autism evaluation and clearly anxiety is part of the picture, you can go ahead and call it out as a specifier without that person having to already have an anxiety disorder diagnosis. And then lastly, it's a lot of information. Lastly, they also wanted to specify how much support the individual would need for kind of the severity of the symptoms they were showing. So they came up with this level system, with level 1 being requiring support, level 2 requiring substantial support, and level 3 requiring very substantial support. And technically, diagnosticians are supposed to assign this across the 2 symptom areas. Usually, you just see if it's assigned kind of across the board assigned. But in theory, someone could be like level 1 in social communication and level 2 in restricted repetitive behaviors. So what you end up then is with a diagnosis where you just have this one diagnosis, but many, many presentations between all of those combinations of behavioral symptoms and symptom severity and other specifiers, right? And so individuals with severe intellectual disability all the way up to cognitively gifted, socially aloof, to passive but socially active, to like socially awkward, all of these like big ranges in what you can see. So it's an interesting population to work with. And certainly when we talk about therapies next week for individuals with autism, it's going to vary so much based on the individual presentation in terms of what people are recommending and what's really best for a family and for a child. Okay, so now I'm going to move on to the diagnostic process. So how we take some of those symptoms and signs that we're seeing and decide whether or not the person meets criteria for autism spectrum disorder. There's 3 kind of core features of the assessment that I want to talk about. So regardless of who you go to and who all's involved with the diagnostic process, these 3 things should be a part of it. First is some diagnostic interviewing. So parents, other caregivers, are typically interviewed about the child's social communication as well as the child's interests and behavior. So those symptoms we just talked about. And as the person, the diagnostician is talking to the family, they really need to be talking about both what's going on now as well as in the past, particularly if the child is older. because of those things I talked about before, where things can change over time. And so you got to take both current as well as the past into consideration. And especially when it's not real clear cut, from talking to parents and caregivers and observing the child, it's really important to get information from others who would know the child well too, like daycare providers, teachers, grandparents, to briefly interview them or to get information from them as part of the process. Second part of the assessment is some sort of systematic observation. For a long time, the Autism Diagnostic Observation Schedule, the ADOS, has been a very popular measure. But with the pandemic, the way that we administered things kind of had to change. And so we couldn't do as many things with the ADOS as we used to be able to do with the masks on or seeing people over telehealth and stuff like that. So people started thinking about like, hey, what are some of those other things that we used to use, or what are new things that we should be developing? So this is a really pretty exciting time, because you see a lot of different things people are trying out right now in terms of observation of the child. The ADOS is still very good and the most popular thing probably that people are using. But there are other measures out there that are valid and good ways to get the same kind of information. So what people really like about the ADOS is it's set up with a series of activities where you basically set up the situation to look for behaviors that would normally happen, like eye contact or pretend play or the child initiating social games with you, that sort of thing. So you set those situations up and then look to see what happens and score them on a standardized scores. And then the other thing people like about it is the materials are really set up nicely so that depending on the age of the person and their language level, you pull out different materials and do different things with them. So this is a test where you can give it to a child as young as 12 months of age, and you could give it to an elderly individual. It would look very, very different, but kind of everything's included with that testing set. So just focused here on younger kids. So when we are seeing more like an 18-month-old or a 24-month-old, and we're doing something like the ADOS, those are the kinds of things that we're pressing for, that we're trying to set up to see them do, and then that we're scoring on some standardized ratings. So they're smiling, how much they're attempting to get others to look at something they're looking at, or if someone else is looking at something, can we get them to look at it as well? What they're doing with eye contact and coordinating it with gestures or vocalizations or words. If they're interested in having fun time playing some social games like peekaboo, that sort of thing. Are they showing and giving toys to others? In terms of communication, how are they communicating with others? And that includes gestures. Is there anything atypical about their vocal intonation or some early like repeating of words, some early echolalia? With behaviors, we're looking at those sensory things, and if there's any repetitive motor mannerisms like hand flapping. And we're also looking at some of that repetitive play. So just like opening and shutting a certain piece of the toy, or flicking a certain piece of the toy, or spinning the wheels on the toy car, that sort of thing, with really limited interest in kind of initiating with others or showing them those things. Third part of the assessment is to be sure that the diagnostician is taking into consideration other aspects of the patient's development. So things like their early thinking skills, or their thinking skills at any time, really. So cognitive functioning, language skills, other things like motor or fine motor or gross motor, all of these things, adaptive functioning can be really important. And sometimes that is just looking at some screening that like a pediatrician or someone has done to identify, okay, there's no concerns. Other times it is adding that into the battery and really trying to get an estimate of it if it hasn't been done before and there are concerns. And these are really helpful for intervention planning if you do diagnose autism, but they're also really helpful if you don't diagnose autism, because it starts to suggest to you some of those other areas that could potentially be a differential diagnosis, a different diagnosis for that individual. Okay. Next up, we're going to talk about what causes autism. And first of all, there's not just one cause. The fancy word for that is equifinality. So the idea is that we know there's multiple causes for autism spectrum disorder. And basically these different things are all presenting similarly or very similarly. It's that outcome that we call autism spectrum disorder. So if you ever heard the word, people use the word autisms, this is kind of what they're referring to, is that there's actually, multiple things that are all resulting in the same outcome, the same presentation. One thing that we know is a big factor and that we've done a lot of work in is the area of genetics. And about 15% of the time, give or take, they can now say there's a specific genetic abnormality that explains why an individual has autism. So kind of a classic example is a genetic disorder called Fragile X. Many individuals with Fragile X also meet criteria for autism spectrum disorder. But we knew there were a lot of less apparent genetic disorders that were out there, and that if we just started to play nicely together as researchers and really pool our data, we could maybe figure out a little bit more about some of the smaller genetic abnormalities that may be a contributor or cause to autism spectrum disorder. So there was a nationwide study called Spark. You may have seen their commercials on TV before. And Iowa was one of about 30 sites that were studying people with autism and their genetic makeup. And the idea was that we were going to try to really improve the lives of people with autism by identifying the cause of autism or causes of autism, and being able to really then inform more effective therapies, treatments, supports, and services. And in the end, they recruited more than 50,000 people to the study, and lots of triads where they had child with autism and DNA samples from the child and both biological parents. And what they did, actually, let's go to the next slide here real quick, is across all these centers, they pooled the data and were able to really say a lot with a lot of statistical power, because they were working with so much more data than just all these little places working in their own individual labs. And they have a really great website with lots of summaries of their research to date. And they're still publishing off of this data set and will be for a long, long time, with lots of resources available on the website as well. And just as an example, someone wrote in with a question about research on where we're at with research on GI problems and autism. And there's a lot on the website that uses Spark data to talk about this. There's webinars, there's summaries of their research. So this is just one example, but if you go there and use the search bar, they've done a lot of work. And I'll just say not all of it's genetic. Because there were so many people in this study, they've also kind of thrown out some other questions that are unrelated to genetics. I remember early in the pandemic, they did a study about how families were kind of coping with online instruction and that kind of stuff. And so it really had nothing to do with the genetics, but they had such a big pool of participants that they could get a lot of answers quickly. Okay. So there's genetics, but there's also genetics and early environmental factors that people are looking at. And these are just a few. So advanced parental age, both mother and father's age at time of conception, maternal illness, extreme prematurity, difficulties during birth. These are all things that we know put kids at risk for autism spectrum disorder. So trying to understand those mechanisms. Here's some other potential causes being actively studied: immune system functioning, exposure to pesticides and air pollutants, what's going on with myelin in the brain, the insulation for our neurocircuitry, and prenatal folic acid. That's been an area of research as well. Just a few. There in the top left corner, just a headline from our own work here at Iowa. We have a federally funded center called the IDDRC, the Intellectual Disability Disorders Research Center, and they are doing a lot of research on early environmental factors as well. What we know does not cause autism. One thing is the first theory of what caused autism was that it was bad parenting. And specifically, the theory was called refrigerator mother, meaning that mothers who were kind of emotionally cold and unkind and to their kids cause autism. And the person who came up with that, or like that was a big proponent of that, was a fraud. They found out like they fake their data, and that theory has been discredited. Another early theory is the MMR vaccine. And since then, there has been so many studies, and they're to be summarized there at the CDC website, where they've looked at the link between the MMR vaccine and autism spectrum disorder, and there is no association. And actually, that was a situation where one of the famous studies as well, where the data was fraudulent. Okay, and lastly, I want to talk a little bit about infant sibling studies and the early signs and symptoms of autism spectrum disorder. And this is things that have been pretty recent findings, maybe in the last 15 years or so. Just like that genetic disorder data, but with Spark, where they're sharing it across labs. Everyone who was studying the earliest signs and symptoms, not everyone, but many of the places where they were studying that all got together and created a consortium where they were combining their data across research labs to be able to make some more robust findings about these things. So what they did was they decided to start studying the infant siblings of a child with autism, because the prevalence rate for siblings is much higher than for the genetic population, or for the general population, sorry about that. So the prevalence rate for siblings is more like 10 to 20%. And again, that just has to do with that genetic piece that we know is present. And so they started studying these baby siblings, and they tried to figure out, okay, when we get to 18 months, what are the symptoms that are going to be predictive of, yes, this child is going to meet criteria for sure at age 3? And these were the combinations of symptoms at 18 months that were particularly stable for the diagnosis. So if a child had poor eye contact and limited gestures and limited like showing and giving things to others, they were pretty likely to have autism spectrum disorder at age 3. Another combination is kids with okay eye contact, but have a lot of repetitive behavior. And again, that limited giving and showing of objects to others. That combination also was particularly stable. And so most of those kids met criteria for autism spectrum disorder at age 3. So those are ones that we want people to be particularly thinking about when they're kind of in that gray area at age 18 months. There were some differences even early on in how much babies were attending to social stimuli, and how much they were getting kind of stuck on repetitive or interesting looking things, even very early on. And a lot of the baby siblings in addition to being at risk for autism, are at risk for other developmental problems, such as language disorders and ADHD. And sometimes these infant siblings grow up to have some symptoms of autism spectrum disorder, but not enough to meet diagnostic criteria. And that's called broader autism phenotype. Finally, one thing they've looked at is when they do some early intervention with infant siblings, they tend to respond well to that. So that's helpful for their social communication and language and such. So the idea is that they were trying to see kind of where those changes happen, and looking at this idea of called developmental cascading, where basically things start to kind of build on each other. So some of those core social communication things, like everyone's, orienting to the same thing and talking about the same thing. So the child's looking at a toy and the parent's looking at a toy and they're both interested in it, looking at it. Like that's a core thing that if it's not happening, it can start to disrupt other social communication skills down the line. So understanding those trajectories is really important, both for intervention as well as catching things as early as you can. So they used to think that some regression in skills like social engagement was kind of rare and only happened to some of the kids. But it turns out if you kind of track this stuff as it's happening, rather than ask about people like retrospectively, it's actually pretty common. And it happens earlier than a lot of people think. So the big trajectory to kind of see is between about 9 and 15 months. Kids who go on to develop autism spectrum disorder start to have a lot of regression in things like their social engagement. And like I said, doesn't correspond very well to what people remember. If you ask a parent or a doctor, it doesn't really matter who you are, of a 3-year-old, what they were like back at age 18 months or 12 months, memory for that's pretty faulty. So it's best for people to be tracking this as they're going, and really start to think about, if they're starting to see some differences at 15, 18 months, feeling confident in referring the child on for diagnostic evaluation. If you like thinking about this kind of stuff or want to know more about autism and toddlerhood, I think this is a really nice course that's free. There's a lot of things on this website that are behind a paywall, but this free 3-hour course on autism and toddlerhood is quite good. And there's also a nice video glossary that shows a lot of early signs and symptoms of autism spectrum disorders. So again, if you're interested in kind of that earliest presentation and that trajectory over time, I would take a look at this. It's out of Florida State. Okay, so I think I have a little time for questions, and I also put my email address up there. So if you want to email me later, that's fine as well.
We do have a couple questions here in the question and answer box. The first one is, what type of genetic testing was included as part of the SPARK study?
SPARK study used saliva, actually. They did saliva samples. And then as far as the kind of testing they were doing, they were actually looking at a pretty fine level in terms of like DNA sequencing, a finer level than I think most people would get if they were going to like a genetics appointment at a hospital. They just used a different technology or a different methodology basically for analyzing things, where they were looking at really small differences.
There's another one that says, can autism come from a parent taking specific drugs?
So we know, I don't think I had this up on the slide, but we also know like, yeah, so in utero exposure to some drugs, puts kids at risk for autism and other developmental disorders. We think about that too in terms of substance use. I don't know the research on over-the-counter things very well. I know that there's been a lot of commercials about a class action lawsuit with Tylenol, but I don't think the research that I have read that it's real clear cut yet.
What should you be looking for in a 3-month-old if you're concerned about autism?
In a 3-month-old,
Yeah.
I would say that is probably too early to be looking, but start charting at about and taking some notes at about 9 months of age of what the child is like in terms of kind of their playfulness and sociability and eye contact and kind of back and forth with things like peekaboo, and then start tracking forward from there to about 15 or 18 months and making sure that that's staying that's increasing or kind of staying at the same rate.
Have you seen cases of autism connected with Angelman syndrome?
Oh, that's a good one. So typically no, because typically no, because the social piece doesn't usually quite work out. But a lot of the therapies and interventions recommended are very, very similar for those two disorders.
There's one that says it sounds like the interventions are intended to get kids to mask as neurotypical, which has been controversial among adult autistics who went through this type of interventions. Do you have any thoughts?
My thoughts are that I think we need a lot more research there. And we're in a good position to be getting that both retrospectively and prospectively at this point. And I suspect there's going to be a lot more of that published in the future. So I'm looking forward to see what people say in terms of the science there.
Is it common for a doctor to ever go back on an autism diagnosis?
It is not that common. It does sometimes happen where people feel pretty confident and then see a child back and it really looks different. The most common difference is for a child to go from symptoms that look more like autism to symptoms that look more like ADHD. And in fact, there's been some research in that area where, some of the best people in the world, some best diagnosticians in the world, where they've been very confident that it's autism. And then it kind of switches in terms of presentation to looking a lot more like ADHD. So they've been trying to understand that phenomenon genetically as well.
And then there was a question that was submitted. How long is the wait list at the University of Iowa?
Too long. It's a short answer. It depends a little bit on the age of the child and unfortunately kind of which clinic as well. We're trying to get things kind of evened out between clinics. But we do our best to get younger kids seen sooner because, I'll talk about this next week, but because of the importance of early intervention. But even some of the waits for young kids are very long right now, both at the university as well as at other centers too.
And then one more. Why do you think the prevalence of autism has increased since 2000?
So I think a lot of it is what we call autism now versus maybe we called it something differently in the past. And actually, they've done some research on this too. It's called diagnostic switching, where maybe in the past individuals would be diagnosed with intellectual disability and now are diagnosed with autism spectrum disorder instead. And similar with ADHD, sometimes with some of the more qualitative differences in social communication, in the past may have been chalked up to ADHD, are now called autism spectrum disorder. And there's certainly been a widening of the criteria over time as well.
Thank you.
Mhm.
And thank you all for joining us today. Thank you, Dr. Pelzel. And we will see you all next week for the session on therapy options, and be looking out for an email with links to the recording and other resources shared during the presentation.
Thank you.
Have a nice day.